Now we are going to present Professor Dr. Craig Smallwood. He is from United States, Harvard School of Medicine. He's member of National Board of Respiratory Care, American Association for Respiratory Care, and he is reviewer of Journal of Parenteral and Enteral Nutrition, Journal of Pediatrics. He's going to talk about gas exchange monitoring concepts and technology.
Shukran. Assalamu alaikum. Thank you so much for having me. It's a real honor to be here with you. This invitation and trip really happened to the last minute for me, but I'm grateful to the committee and really look forward to meeting many of you who I haven't already. And hopefully I can tell you something a little bit about gas exchange and nutrition monitoring that I know. Thank you very much. So I'm a respiratory therapist in a previous life. That's what I like to say, because for approximately 5 or 6 years ago, I worked as an RT caring for critically ill babies and children in the ICU at Boston Children's Hospital. Since then, I've transitioned to just pure research, so I did clinical research, and now I approach research principally from a bioengineering perspective, which means a lot more technical stuff. So this is the first in a 2-part lecture series in which I'd like to bestow upon you an overview of how the technology works, and then the next lecture tomorrow on gas exchange monitoring will be a lot more clinical and practical, and hopefully give you some tools to improve your care. So part 1, concepts and methodology. So as an overview, this I took from, it's a review article from the American Society of Parenteral and Enteral Nutrition, published in JPEN. A really good friend of mine and colleague wrote this review that kind of went through all the evidence as to why, when and why and how we would want to monitor a gas exchange and energy expenditure. And you can see the levels of evidence aren't really that great. The scale's from A to E, and so we're talking about pretty much the lowest level evidence that we have. And part of my motivation as a researcher is to try to fill these gaps. But in the meantime, it's really saying that measuring energy expenditure should be assessed through critical illness, both in neonates, newborns, and pediatric subjects. And that's because there's a tremendous heterogeneity, basically, in the energy, in the way that patients burn energy as they're acutely ill, and then they migrate through their illness. So this is where we're going to go. We're going to talk a little bit about metabolism, and Dr. Ethan's lecture, I think, was a great segue into why this is important. I do have some more specific indications for gas exchange tomorrow, but today we're going to talk about metabolism a little bit and then the methodology. My personal philosophy for critical care is really, I mean, I guess part 1, I think the disclaimer is I'm a bioengineer, so you're going to get to know about the technology. That's kind of what I'm really interested and passionate about. But I think the clinical important piece is if you as clinicians can understand a fundamental overview of how the technology works that we are measuring at the bedside, then you'll be much more equipped to interpret the results more accurately and make a more clinically informed decision about what you want to do with those measurements. So metabolism. This is basically the pathway, right? We eat, we metabolize, and then we exchange gas. This is an overview, starting with the 3 principal macronutrients: proteins, polysaccharides, and fats. Principally, we like to be aerobic beings. That's not always the case if you're exercising in the gym very diligently or in some stages of critical illness. But in general, aerobic metabolism basically is going to take those macronutrients, metabolism, consume oxygen, spin off some ATP, the energy, and then produce CO2 as a byproduct. And then once we have that at the cellular level, we need to transport all those gases to and from to ensure that we keep our patients as healthy as possible. And this is probably my favorite graphic to overview the whole pathway. But we start, and this is our machine, right? This is our cellular machine that's basically metabolizing those macronutrients. So if we talk about CO2, we're going to be talking about CO2 being produced at the cellular level. And that's basically, this knob is going to be the energy expenditure knob. So that means you crank it up, the energy expenditure increases in your patient, and you're going to have an increased volume of CO2 being produced by your patients. And then this is the concentration. Really, CO2 can go everywhere in your whole body. It can permeate fat. It's a tremendously diffuse gas. But if we talk about in the blood, this is really the concentration of CO2 in the blood. And then we can turn this knob up or down basically to increase or decrease the ventilation of that CO2 in our patients and eliminate it. So we're going to talk a lot about VCO2. The V dot, basically that's the physics notation for flow, or the mathematical notation, so the flow of gas outside of our patients. And we can similarly talk about oxygen consumption, the flow of oxygen in our patients. And that's basically the overview. So we need to measure all this stuff accurately and diligently. So this is what we're going to do. We're going to talk about VO2, and there are two main components, right? You need to know about the flow. So our patients breathe in and breathe out. So inspiratory and expiratory volume. And we also need to know the partial pressure of oxygen, both inspired and expired. So the gradient between those two is going to be how much oxygen is being consumed. And for VCO2, the volumetric elimination of CO2, same deal. Inspired, expired volumes, inspired, expired CO2 concentrations. And then I put this in brackets here for energy expenditure. In 2 slides, I'm going to show you the equation to put all these things together. But urinary nitrogen is a byproduct of protein catabolism. And in the purest sense, you need that information in order to calculate energy expenditure accurately. However, subsequent investigations have shown that if you ignore the urinary nitrogen concentration, then it only introduces an error on the level of like 2 or 3%. So for me, that means that less people have to get their hands dirty collecting nitrogen or urine samples to get urinary nitrogen, which is good news. So let's talk about a little bit of technical overview of how we're going to measure these things. So this is an oxygen sensor. I'm going to talk about 2 different technologies, paramagnetic. This one's really cool. So what's really interesting about oxygen as a gas is it's paramagnetic, and it has a tendency to be attracted to a magnetic field. So what happens is if you have a device, so a GE ventilator, for instance, that has a gas exchange module right in the side, this is the technology that's incorporated there. So basically how this thing works is this is what the internal guts look like. This is just a little picture, right? Or a hieroglyphic, I could say. These little spheres, these green balls, are filled with nitrogen. And essentially, you introduce an electromagnetic field. So you guys know, like, if you put like a little coil, introduce some electricity, you can get an electromagnetic field here. And so when oxygen comes into this little device, it's going to try to displace this little nitrogen ball. And then there's an electromotive force. Basically, you're trying to twist that. And the degree of force that is produced inside this machine is directly proportional to the concentration of oxygen. So that's your oxygen concentration. Another way is every ventilator principally has a method to assess the fraction inspired of oxygen concentration, just to make sure that when you set it to 50%, you're actually giving 50%. And if you guys interact with ventilators a fair amount, you'll know that from time to time that device fails, or it tells you that there's an error or discrepancy between that which you set and that which you are measuring in the patient's ventilator circuit. But this is the device. It's called an electrochemical cell or a galvanic cell, and it's basically a type of battery. And there's a series of interactions that occur in here, but the crux of it is that when oxygen is introduced, there's a chemical reduction. It turns into a hydroxyl ion, so an oxygen and hydrogen, and basically this little device spits out a little voltage. And the higher that voltage is, the higher the oxygen concentration is. So that's how we get it. Those ones run out. Just like batteries, you have to replace them. So that's kind of the bad thing about that. And then my favorite, the thing that I love about mechanical ventilation is monitoring CO2. And I have one lecture basically just dedicated to capnometry and capnography in the next day or so. But basically this technology is spectroscopic, which is just basically using light to infer the concentration of a gas in the air. So what this thing does is, this is our breathing circuit, this little gray box, and these little black dots are the carbon dioxide molecules. And there's an infrared photodiode, so just a little infrared light source here. And then it's going to shine this across this source, and then we're going to measure it on the other side. And carbon dioxide as a gas absorbs that light and starts to vibrate a little bit. But basically you get a discrepancy, so you have a set amount of light that is shone from this side, and then you measure how much came out that other side, and the discrepancy between those two is the CO2 concentration. The important thing about these different methodologies, this one It can be sensitive to motion artifact. So if you're jiggling the device a whole lot, that's usually not a problem. But during transport and stuff, you certainly wouldn't want to apply that one. This one runs out of batteries because it is a battery. And this one is sensitive to like a good window. So if you have water condensation or secretion buildup inside that little monitoring window, then those would be limitations. You'll start to see inaccuracies. And the last couple, mass spectrometry is really like I think it's more of like a bench side methodology. But it basically sorts based on ions and all of this mumbo jumbo that I think is less important clinically, but I just wanted to put it up there because it is used in a handful of devices that are trying to get approval, at least in the United States. And lastly, we need to measure flow, and this is really the same technology that's in ventilators. So there's all kinds of good technologies to assess flow rates, even in newborn children. So historically, I think we've had a lot of trouble as a field getting really accurate tidal volume and flow measurements in neonates because the tolerances just need to be so high that the technology just really wasn't there. But recently, and even in these ventilators that do even from neonates to children to adults, have technology or proximal flow sensors that enable us to measure these things accurately and sufficiently for gas exchange purposes. So the Haldane Transformation, we're going to get to putting all these things together in just a moment. But the Haldane Transformation basically is, if you read anything to do with indirect calorimetry or gas exchange, you're going to come across the Haldane Transformation. And it's really just a shortcut. That's all it is. It is medicine and science, so you always have to name whatever you find after yourself. That's just kind of the rule, I guess. But for VO2 and VCO2, this would have been the equations to put all those things together that we just talked about. So to step through this, so for oxygen consumption, we have inspired gas volume or flow, inspired concentration minus expired volume, expired flow, and then you can get the volume of oxygen that's consumed. And similarly for carbon dioxide elimination. So what the Haldane Transformation tells us is we don't want to measure all this stuff. And I think this is of interest to people who build devices because they want to spend less money and they want to make the device as simple as possible, which also has clinical benefits because they'll be more reliable and less likely to break. So the more simple, the better. Really the crux of the Haldane Transformation is that nitrogen gas is physiologically inert. So that means we don't use it, we breathe it in, we don't really absorb it, we don't break it down, we don't do anything with it, we just exhale it. So if we look at the three main components of each breath, when we breathe in, oxygen and nitrogen. When we breathe out, oxygen, nitrogen, carbon dioxide. And what the Haldane Transformation does is say, if we know the concentrations of those two out of the three gas concentrations, so if we're measuring oxygen and carbon dioxide, then we only need to measure one of the flows. So we can either measure the inspired flow or the expired flow. And the reason that's important is because when you alter the concentration of a gas, you alter the volume. Because carbon dioxide and oxygen have different densities. So if you just change the composition, the volume has to change of that gas. And it becomes important when we put these things together to estimate energy expenditure. So basically what this thing does is say, you know what, we don't need to measure inspired volume anymore. We can get away with just measuring expired. And that's the Haldane Transformation. So anybody seen a direct calorimeter? I've never seen one either myself. But basically what the thing does, calorimetry is the study of heat, really. That's what that means. And so there's this thing called a bomb calorimeter. And it's not a scary device or anything, but it just means that you put something inside this little tub here. And so, I mean, this is just my favorite kind of chocolate bar. It has coconut in it. But you put this inside this little device. You ignite it, you set it on fire, and then you look at how much heat is lost in this tub of water. And that's really the definition of a calorie, right, is how much you can heat up 1 liter of the amount of energy required to heat up 1 liter of water. So that's what we're talking about. Obviously, we're not going to stick our children inside here and burn them, but that's where the measurements come from. So that's direct calorimetry. We want to talk about indirect calorimetry. And indirect calorimetry basically takes the components of combustion. So we have the thing that we're actually burning at the cellular level, that's our macronutrient. And then we also have the composition of the gases that when we burn that thing, there's going to be a certain amount of oxygen consumed and a certain number of, or a certain amount of carbon dioxide produced. That's indirect calorimetry. And so there's a couple of different devices. There's a closed circuit. So this is kind of like an anesthesia circuit, basically. So you could scrub out the amount of CO2 and put it in like a some sort of like mineral deposit type thing, if you guys have seen those before. There's this thing called the Fick equation, which is really kind of a poor estimate of VO2, to be honest, but it looks at the arterial and venous oxygen difference. And for some purposes, it's okay to use that to estimate cardiac output, but for calorimetry, not so great. And then I love this one. I found this is like 1915. This guy has a Douglas bag. If you guys have heard of that, it's basically just one bag that he is just exhaling. So he's inhaling from the air and exhaling all through, and then there's going to be a reservoir here where he collects that. And then the technician in the early 20th century would measure how much volume was in there and calculate the CO2 and O2, and then go from there. So, but this is really what we talk about. So if you guys have seen an indirect calorimeter, the setup looks like this. So we see the child is intubated here. They don't have to be intubated, but this one just happens to be. Mechanical ventilators, we have the inspiratory circuit, expiratory circuit, and it'll pass over humidifier. And these are where the connections are. This is the indirect calorimeter right here. So you can see there's this little line here, goes on the wet side of the humidifier. And if you were to apply this to a patient, that's what you would do. So this is going to aspirate at a set flow rate, and it's going to measure the inspired concentrations of O2 and CO2 simultaneously. And then on the exhaust port of the ventilator, so the patient breathes out through the ventilator, goes through the assembly that controls PEEP and measures the expired concentrations over here. And that's just really the expired flow. And so those are the 2 points of measurement. The interesting thing, and the thing I've spent a lot of work recently over the last few years looking into in our neonatal and pediatric ICU, is utilizing the measurements on the mechanical ventilator. So a lot of ventilators, and these are just a handful, I know there's many more, there could probably be dozens on here, of different devices. Many of them, modern ventilators, have either incorporated as standard or as an option a CO2 monitor. And typically, when we're talking about CO2 monitoring, we normally just care about capnography or end-tidal CO2. But a lot of these devices, these ones in particular, can measure CO2 elimination, VCO2. And this is from a review paper that I published that looked at each one of those 5 devices, and then also tried to spell out what the specifications are if you're interested in actually purchasing one of those. One of my pet peeves, by the way, I know that we have some corporate friends in the next room, is that oftentimes people will build these devices and not simultaneously supply the clinicians with good error data. So you can see for CO2, I mean, if we're measuring end tidal, they'll give you a range. But then when it comes to VO2, look at how many are not specified, or they just tell you a range. So it doesn't tell you anything about the actual accuracy, and that becomes problematic when we want to apply these things to newborns who are at the extremes of the capacity of the technology to actually measure. So this is the open circuit indirect calorimetry with a dedicated device. And then this is a setup, same device, but now you can use it on spontaneously breathing children during room air. And my experience in Boston is that most of the neonates that we measure will be using this canopy type methodology. And this methodology is almost the exact same except for one important difference. So we measure, you put this over, there's actually a drape that kind of hangs down here trying to make as much of an airtight seal as possible. And what happens is right here, there's a little port. We're going to measure the fresh gas concentration, so that's just the partial pressure of oxygen essentially, as well as CO2 just in case there's some in there, but if there is, we're in trouble. And then the patient breathes in, exhales, and then through this exhalation port, it's aspirated back into the device by a specific sample flow rate, and then measures the concentrations of gas there as well. And so what you can do is get a non-invasive metric of energy expenditure with a canopy setup IC device. So this is probably one of the most important papers and names that you'll hear when we talk about indirect calorimetry. It's the Weir equation. So the Weir equation, J.B. Weir in the 1940s and 50s published a series of papers that were really a landmark when it comes to gas exchange. And basically what it does is to estimate energy expenditure, or really to measure energy expenditure, resting energy expenditure. You take the two components of gas, as well as that urinary nitrogen concentration, put all those things together, and you can get energy expenditure in kilocalories per day. And the reason why that's important is I think mostly self-evident, but what we're learning in pediatrics, newborns, and in some cases neonates as well, is that there's a tremendous heterogeneity and response in the amount of energy that patients are actually burning. And there's emerging evidence, albeit not great at this point, that nutrition therapy is a little bit of a Goldilocks conundrum. If you guys are familiar with Goldilocks, it's basically, you know, she's interacting with some bears, and she says she doesn't want her oatmeal to be too hot, she doesn't want it to be too cold, she wants it to be just right. And energy prescription is a similar phenomenon. So you don't want to overfeed, you don't want to underfeed, you want to feed just what the patient needs. And so this is the equation that takes all those measurements and does that for us. The modified Weir equation basically just ditches this urinary nitrogen concentration, and this is what we talk about. So another really important feature of gas exchange and indirect calorimetry is steady state determination. So if you guys have ever seen an indirect calorimeter set up, it's essentially a snapshot. These devices weren't necessarily meant to work for long periods of time, but our patients are living and breathing and burning energy 100% of the time. So we needed a methodology essentially to take a snapshot about a 30-minute window and make sure that that 30-minute snapshot reflected what the patient is doing for a full 24 hours. That's one of the important metrics of IC. So this came from McClave et al. In the Journal of Parenteral and Enteral Nutrition. And what they did was look at a number of different definitions. And you can see that this is a 60-minute test. They also measured for a full 24 hours. And they wanted to find out which statistical feature was the best that related that snapshot during that 1 hour measurement to the full 24 hours. And the result is basically, they say, the definition of steady state are 5 consecutive minutes, so 5 minutes is all you need, during which the variation in VO2 and VCO2 is less than 10%. And that's pretty much it. So you're basically just looking for a little window where you don't have a whole lot of noise. That's basically what that definition does. And those are going to be on board the actual IC to ensure that we don't have to do that in our heads or on calculators or on our iPhones. So some limitations. Then I have a couple of studies from my lab just looking at some comparisons in terms of accuracy in pediatric and neonatal children. A lot of devices won't measure accurately at high concentrations of oxygen. Some of them do, but you want to make sure that if you apply these devices that you're using it with the manufacturer's specifications. They're going to be prone to, well, sensitive to system leaks. So if you have an uncuffed endotracheal tube, as is more common in infants, but less common, I think, every day, if you have a leak, a system leak, then the amount of gas that is escaping around the endotracheal tube is going to throw off your measurements. And then calibration, you obviously need to calibrate it. And then you have to make sure that the overall setup and timing is correct, as well as calculating steady state. So there's a couple of things that I'll leave you with, and then I think we have some time for discussion. But so the device-to-device comparison. So one of the things that I think is tremendously important in anything that we do in medicine is that we're actually measuring something that's accurate and to the best ability that we can before we make a clinical decision based on that measurement. And second, there's I think an increasing need for non-invasive measures, particularly in neonates. I think in general we're less prone to intubate these children. So what you want to do is come up with methodologies that can allow you to measure energy expenditure during non-invasive ventilation. So this is data from my work. We compared basically a device that was incorporated into the ventilator. It measured VO2 and VCO2. It was a GE device. And what we wanted to do was compare it to measurements using a standalone indirect calorimeter. So it was a device-to-device comparison. And if you guys have seen a Blond-Altman plot before, it's basically this scatter plot. On the x-axis, this is the mean of the measurements. So I'll just show you VO2 here. So this is VO2 between the two devices. So you take the average of the two devices. So I measured it once with the indirect calorimeter, once with the GE device that was a little sensor at the endotracheal tube. and then look at the error between those two. So you can see we enrolled 19 total subjects, and each one of these dots is one subject. So the overall mean VO2, this would be closer to like an infant or a newborn down here. You can see that in this case it was minus 20%, so there was a 20% discrepancy. But there's a lot of heterogeneity in the overall population. So what we decided to do is basically say that these devices weren't equivocal. In some cases, for CO2 they were, but for VO2 they didn't seem like they could be compared to each other with 100% confidence. We also compared the absolute performance of some devices that measure VCO2 that are standalone, so not necessarily incorporated into the ventilator. This is the Philips NM3. This is a little box basically that measures end-tidal CO2 as well as volumes and flows coming out of your patient. And this is a portable indirect calorimeter device. And so we're looking at the same type of plot, only this time we're not comparing the devices. We manufactured a system to validate it. So we're setting a specific amount of energy that we want to estimate, and then measuring how much came out of the ventilator itself, or the device to measure it. So you can see that both of them kind of underestimated by about 10%, but 10% in ventilation and in healthcare I think is not too bad. And this is a comparison between a new and old GE device. Their newer module did better, and that was important, and perhaps we can see it next door. All right, so the last couple slides here. We're going to talk about steady state. So one of the things that really is a difficulty in the NICU and PICU is when you apply the device, you bring in the indirect calorimeter, the technician set everything up, you get a good test, you think that you have good results, you go back to the lab and run the statistical process to ensure steady state, and there's no steady state. So it means your test is invalid. Basically, we wouldn't suggest in that context that that number be transmitted to you guys, the physicians, to make decisions about nutrition, and it was all basically for naught, and we'd also want to do another test. What we did was say, okay, this 5 minutes is just a thing that was kind of made up, and it seems to be a good definition, but 5 minutes we just can't get it in children for whatever reason, not as reliably as our adult colleagues. So we basically came up with another definition. We looked at a shorter time window. So we looked at 3 minutes and even 4 minutes. And that's like a tremendously small period of time to say relates to a full 24 hours of energy in your child. But what we did was during a 30-minute test, we would take different snapshots, so different 3 minutes. So if it's 3 minutes during the beginning, and then you had a bunch of variation, and then you went back into those nice steady 3 minutes, then we would average those together, and that's what our definition of steady state was. And subsequently, we were able to bump up the overall proportion of children that got this test much higher in terms of achieving steady state. So that's a very practical tool that we use. And I'll leave you with this. This is really experimental, but it's kind of meant to intrigue and get some discussion going. But we know that neonates are receiving a lot of high flow and non-invasive ventilation, but we have no good way to measure energy expenditure on either of those devices. So this was my attempt in the lab to come up with a system to be able to measure energy expenditure and VCO2 in kids who are breathing on non-invasive support. So this is basically, I used the same kind of calibration system that we did. So you can pretty much ignore everything outside this box, but imagine this was the patient inside here. We'd put a canopy on top of the patient who's breathing with a mask or nasal prongs. And then similarly to the canopy device for spontaneously breathing children on no support, we would then aspirate the gas flow coming out of there, measure the gas concentrations, and estimate energy expenditure. The important feature that we found was that we had to closely match the pump flow, the amount of gas that we're aspirating out of that chamber, to match the patient's total inspired gas. So during non-invasive ventilation, we know there's tons of leaks. And so the amount of flow that's going into that patient and coming out of the ventilator is much higher than their actual minute ventilation, because the ventilator is going to be compensating for leaks in the system and around the mask or nasal interface. But we had to look at that total flow rate and match it specifically to the indirect calorimeter. And that's basically right here, 1. So the higher this dot to this dashed line was the increased accuracy. So the closer those two things met was the superior accuracy. And this is the same data in a different plot, but we just looked at the amount of air that was entrained in excess of that which was set. And basically the bias was limited the closer to zero those two numbers were. So the reduced difference meant improved accuracy. And in general, I think that I know that this was kind of a more technical talk. I am a bioengineer after all. I think it's important to take away a few key features. I think that when you're measuring gas exchange, tomorrow I'm going to talk about the clinical indications and how to actually interpret these things, and also what the device actually looks like and some general indications. But I think the important features of this talk are that there are a number of limitations of gas exchange monitoring, and hopefully you can remember that a system leak is not good. The calibration needs to be appropriate. You need to follow the manufacturer's specifications for what the inspired concentration of oxygen is, as well as the limitations of overall gas exchange monitoring and estimates of energy. But with that, thank you very much, and shukran.
Thank you for your very distinguished speech about gas exchanges. And now just floor for questions, 5 minutes.